Hello, I'm Donal McCauley, and welcome to this Medics Voices conversation. Today I'm talking to Fern Hauck, who is Professor of Family Medicine and Public Health Science at the University of Virginia. But Fern, let's go back to the very beginning. Tell us about your interest in medicine and how it all began.
It really goes back to my own GP. Back then, when I was a little kid, we didn't have family physicians yet. We had GPs, and I had mononucleosis, and I was very sick. I didn't know I had mononucleosis until my GP came to the house, and he was kind of eccentric. He had this big mustache and not your typical, family type doctor. And anyway, long story short, he had me jump up and down on my bed to see how tired I would get after jumping up and down a few times, which I did. And he examined me and no blood tests, anything like that. And he said, "You have mononucleosis," which I still agree with the diagnosis all these years later, now that I'm a doctor. And I was so taken by him and so I loved him. He was just so warm and I loved the eccentricity. I always did love eccentric people. And that's when I started thinking, I want to be a doctor, like just like him. And I remember being at a family event. I think I was about 12 or 13, and someone said to me, Fern, what would you like to be when you grow up? The typical question. And I said, I'd like to be a doctor. And she said to me, "A doctor? Are you sure you don't mean a nurse?" And I said, "No, I want to be a doctor." And back then, women weren't going into medicine quite in the numbers, that they are going into medicine now. So it was considered something unusual. And fortunately, I had parents who encouraged me and supported me and said, "You go for it. If that's what you want to do, go for it." I have to admit that I didn't get that much encouragement from my faculty advisor in college, believe it or not. Didn't think medicine was the right field for women, but I plowed ahead. Fortunately, got into medical school, and here I am now, all these years later.
So you went to medical school, and I've heard you say there weren't that many women in your class, but you've
Mhm.
always been an advocate for women in medicine.
Well, as you said, I had maybe, I think my class was around 130, 140 in medical school, and maybe we were 20, which of course now, most classes are 50% or more of women. So I've always supported women going into medicine. I've always wanted to mentor young girls. I didn't do anything necessarily formally, although I was recruited to be the advisor to a lot of different student clubs, including when I was at Loyola University. Believe it or not, there was no family medicine department when I first went there, and I was in the preventive medicine and epidemiology department there. And I was approached by students who wanted to go into family medicine, so I helped them start a family medicine interest group. But I always had an eye out for the young ladies, for the girls and women. And I've continued to mentor throughout, I'd say my career, both as for medical students, residents, and then now, certainly as a faculty member, excuse me, mentoring residents and early faculty.
Well, as you say, at that stage, there wasn't a lot of family medicine, but you did a family medicine residency. So tell us a little bit about that.
Well, it was interesting because even though I started medical school, really, as I said, wanting to go into family medicine, that was for me. And throughout medical school, when I started, fully expected to go into family medicine. But then I really loved my surgery rotations. So I did a couple of rotations as a fourth year medical student, 1 month doing a surgical rotation as the acting intern, and 1 month in family medicine at the program where I eventually ended up doing my residency in Maine, central Maine. And I compared the two. I compared the patients. I compared the what the lifestyle would be, the relationships that you develop with your patients, the relationships you develop with your colleagues and your mentors. And I thought, family medicine is really what I need to go into, what I feel most at home with. I felt much more at home with the people, with their ways of communicating with patients, the relationship, even just in 1 month as as a student at this residency program, I was able to develop relationships with some of the patients. And I also sat in and helped with several deliveries. And that really did it for me because I just loved doing the obstetrical part of family medicine, both the prenatal care, the delivery part, and then the care of the both the woman and the baby postpartum. So that clinched it for me, and that's the program I ended up going to, which is called the Maine Dartmouth Family Medicine Program, Family Practice Program, which is in Augusta, Maine.
Well, you must have been a bit of a high flyer because you then went on to the Robert Wood Johnson and Case Western. Talk to us about that. That must have been very exciting.
Yes. Well, I want to go back one step, which my first job actually after residency was to start a residency program at Dartmouth Medical School in New Hampshire because they didn't have a family medicine residency program. So I was literally recruited straight out of residency with one of my other with one of my faculty preceptors from the program. And we went to New Hampshire and we designed a we started to design a residency program and what the family medicine practice building would look like with education in mind. And can you imagine, being straight out of residency? They must have been crazy. Unfortunately, I was there for about 2 years and it looked like the writing was on the wall that the program wasn't exactly going to be going fully ahead anytime soon because of some internal resistance at the School of Medicine. So just at that time I was happened to be recruited to Case Western Reserve. That's where we get into that Robert Wood Johnson fellowship. And Dr. Jack Medalley, he was the chair of family medicine at Case Western at the time, and he called me up one day and said, I heard about you from one of our other faculty members. We'd love to have you take a look. We're looking for new faculty, especially more women faculty. So there's that woman piece again. And he had the most charming South African accent, which I fell in love with immediately. And he was so charming. And then he started telling me about their Robert Wood Johnson faculty development program. And I loved the program. And I said, can I be in the fellowship program and rather than come in as a faculty member? It was wonderful. It was, other than my year in Thailand, where I worked in a refugee camp, I would say the fellowship was probably one of the happiest times of my career. I mean, I've had many happy times, but just having the opportunity to be for the first year, just be in classes. I got a master's degree during that, part of that year. Um, and then the second year of their fellowship was doing our research project. And I studied humanism in physicians. I came up with a humanism scale, and we tested it out in some patients, and we had some outcomes associated with that. And I was proud to be able to get my first publication in the the STFM journal. And at the end of the fellowship, Dr. Medalley said, "Okay, now we'd like to invite you to stay on as a full-time faculty member." And it was at that point that I said, I've always had my heart in global health. Uh, Back in medical school, when I started medical school, I actually had the desire and interest and the expectation that I would spend a good part of my career working overseas in underserved areas. And I was very taken by Dr. Albert Schweitzer, who is a humanitarian, a Swiss doctor, who worked in West Africa. And that's when I switched directions a little bit.
So you switched direction. That was a really brave move to leave behind all this academic achievement. Tell us about that decision-making process, and did you have any regrets?
Oh, no, no regrets at all. In fact, that changed my life. It changed my direction to some extent. I mean, I'm still very much involved in research, but I've also changed my direction with a very strong focus on refugee healthcare. So it was one of the best decisions I ever made. I have to agree, it was scary. So yes, so I did eventually find a position with this organization, and they were running the hospital and the outpatient clinics at a camp called Site 2, which served Cambodian refugees on the border between Thailand and Cambodia. It was a militarized zone, so the public couldn't go freely in and out of the area or the camp. It was very, very, very interesting, very eye-opening. It was my first time ever being in a place like that, in a situation like that. I had practically no orientation. So there I was on day one, joining the team. I became the pediatrics ward supervisor. We were about 15 people. That's all. The camp was divided into two halves. We were on the south side of the camp with about 150,000, 200,000 people. So we were the health providers for that large population. And we basically trained the Cambodian people who were in the camp as refugees to be medics. So they would be equivalent to our residents. So we gave them some training. Then there were nurses, and then there were nurse assistants. So again, kind of like the hierarchy in our system, there was a very strong educational program that our nursing staff took over and was responsible for. I was responsible for the pediatrics ward. So every day we would make rounds in the morning. We'd see who was admitted overnight, um, go through rounds, and then we talk about treatment plans and all of that. And I'd help with examinations. And I learned a little bit of the language of the Cambodians, which is called Khmer, but a little bit to be able to communicate with some of the patients directly.
One of
Mhm,
the things I've heard you say really fascinated me, and that was this business of understanding and communication. And I've heard you say that in many of these languages, there isn't a word for cancer and there isn't a word for depression. That's
mhm,
very interesting for us as family doctors.
mhm. Yes, well, that came to me even more as I started seeing refugees here in the U.S. in my own clinic here in Virginia, because when I was in the camp, I relied a lot on the medics and the local staff to interpret for me. So I didn't necessarily identify some of these communication barriers, if you will, or complexities. But once I started seeing patients directly with interpreters in my own practice, that's when it became clear that there were lots of differences in wording. And so there was the language, and then there's the cultural part. So first, the language, as you said, I remember speaking to a patient who was from Myanmar, and they were speaking a dialect. I was just doing the typical family history, review systems, et cetera. And I asked if any family history of cancer. And you'd think that would be a very quick yes or no question. And then the interpreter was going on and on. And I said, "Excuse me, interpreter, I'd like to interrupt. I thought I asked a simple question. What are you asking about, or what are you talking about?" He said, "Well, in our language, there is no word for cancer. So we have to kind of explain it and come up with a description so that the patient knows what we're talking about." And so the way he said it was the disease that makes you very sick and kills you. Can you imagine? I said, okay, well, let's not let's not use that definition, and so it really made me aware as I was communicating with my patients and with the interpreters that I would be very careful with the words I used. I basically banned the word cancer pretty much from my conversation with patients. I would, when we talk about prevention, or let's say mammograms, I would say we want to make sure your breasts are fine, there's no abnormalities. Same with pap smear. So when I try to teach our residents and other faculty the same, that you have to be so careful with your language, because A, the words have different meaning. B, you don't know what the interpreters are saying. I mean, that's the challenge as well. Then there's the cultural side of things, which is, in my opinion, even the stronger factor in communicating with our refugee patients and immigrant patients.
So you took these major changes in your career, but Tell us how it transformed you.
Well, working in the refugee camp was totally a transformational experience for me. Seeing these people who suffered so much, had lived through the Khmer Rouge, Pol Pot regime in Cambodia, fled for their lives, left everything behind, yet they had so much joy. They were such wonderful people, and they had so little, and they were so appreciative of everything we did for them and the relationships that I built with them and the ability to teach them. And they were so interested in learning. That was what was so transformational. And I felt that I was doing something useful. I mean, there was a huge learning curve for me. And I had heard from others who'd been there before, be careful not to try to take on too much because you cannot fix everything.
Fern, you've talked about the medical aspects of your work with the refugees, but people often come back from working abroad and they look differently on life at home.
Appreciate it. I remember coming back to the US and going into one of our supermarkets. We have these mega supermarkets, and thinking, oh my God, there's so much stuff, and there's so much commercialism in the US. And I really had we call it reverse culture shock. I had it for about 6 months, and the only people I could talk to during that period were people who'd had a similar experience. Because no one really wanted to hear me talk about it here. They wanted to hear for a few minutes and then move on, Fern. So it was interesting to have that, also that reverse culture shock experience, which really taught me again to appreciate the non-commercial things in life, the non to focus on relationships and people and forget about the commercial aspects of what's so consumerism, what is so big in Western society. So.
Now let me turn completely around and talk about a completely different area of your research, and that's sudden infant death syndrome.
Yep. Yep. And I do, it's often I feel like I have two jobs. You know, I have my refugee work, which is literally a full-time job plus, and I have my research, which is a full-time job plus. But I love both. I love my research. And so, yes, I have been doing a research in sudden infant death syndrome. Um, Also known as crib death or cot death in different parts of the world. It's actually morphed into sudden unexpected infant death, but let's just use the word SIDS because I think most people know that. Um, I got a call one day from one of my contacts at the CDC, and she said, we got a request from this public health department of the city of Chicago. They want to look at reasons why they have such high rates of SIDS, particularly in their minority population. Are you interested? So this was something that literally fell in my lap. I said, well, I don't know that much about SIDS. What I learned in medical school and residency, I've never personally even had a patient who had a SIDS loss. Anyway, I will try to make another long story short. So I said, well, yeah, tell me more about it. So it ended up that I put together a proposal, meeting with the public health department, to see what can we do. And we designed a case control study looking at SIDS cases and controls. NIH got interested once they heard about it. They said, well, we'd really love for you to work with the medical examiner closely and collect some tissue and develop some protocols around autopsy and tissue collection. So literally I came up with protocols for a death scene investigation, for autopsy, for tissue collection, large case control study, basically still the largest case control study of SIDS in the US, particularly focused on a Black population. About 3/4 of the infants who died over this 2.5 year period where we were studying the infants who died were African American.
Fern, so you've done a lot of work on the tissue and the genetics, but you did a lot of work on the policy implications as well and the educational implications of this work.
Um, Well, first of all, based on our original study, we did find a lot of the risk factors associated with SIDS in an African American population. And we found that the risk factors were essentially similar to other studies that had been published from New Zealand, England, and other countries. Um, but we also found that a lot of the participants, the parents had not been told the correct position to place their infants in, or some of the other safe sleep practices that they should have been told about. So we identified this disparity that really was contributing to their higher rates of SIDS, that they weren't following, the safe sleep guidelines as opposed to other groups. So that really led to a lot of great policy implications for education and doing more in the city, as well as more nationally to focus on education and dissemination of the safe sleep messages to all communities, particularly those who are at the highest risk. As a result of this work, I was invited to be on the American Academy of Pediatrics task force on SIDS, and that has been quite an amazing experience. We are the group that comes up with the recommendations periodically in the US that are basically adopted by the NIH and CDC and doctors and hospitals throughout the states. And often other countries look to our guidelines as well. So we, as part of that task force, we review all the evidence, all the various case control studies and the best evidence that we can find and make those recommendations. So that's where you see place babies on their back to sleep, sleep separately, but in the same room, all of those things you've all seen in the promoted for the safe sleep. So that's been an amazing experience, and that has, strong, obviously, policy implications. And I feel in some ways, while I love direct patient one-on-one care and that relationship with the patient and how I can help that one person sitting in front of me, I really, really love the opportunity to impact populations. And so that's where my research and the policy piece come together, with the ability to affect populations. And particularly my emphasis has been in underserved communities and minority communities in the US, and really trying to narrow and eliminate that gap in infant mortality and in particular SIDS.
Now, it's fascinating this link between the personal care and the public health impact. And these all came together and been recognized by the American Academy of Family Physicians because you were given a major award this year.
Mm. Yes, I was really moved by that award. That was the American Academy of Family Physicians Public Health Award. And you don't think of medicine as public health, right? I mean, although on the other hand, we very much are community health, right? I mean, that's been a huge part of our discipline from day one. But to be recognized for my work in public health, particularly the refugee piece of things, was very moving to me. I really was that I've received, and you get awards through the years, right? But this one really meant a lot to me. I was given the opportunity to go to Phoenix, where they had their annual meeting, and the award was presented at a luncheon. I was able to invite a couple of my former residents who happened to be there to come, and it was just a really nice celebration. And as I said, I was very happy to receive this particular award.
Fern, thank you very much for chatting to us today. It's been absolutely fascinating. Your work with refugees and sudden infant death, together with all that public health input, it's just wonderful. Thank you very much indeed.
Well, thank you for having me. I really enjoyed this conversation, and I enjoyed some of these unusual questions.